formally start our topic, I will just want to share with you the people who are not this one with the have you used this link which I share sometimes? Okay, so if you want to search any topic, you will just go to this articles, okay, and you will find all that articles topic wise. Okay, like for today, for example, if I want to search, this should be in ICU nutrition we are discussing. So in ICU, and then you will find here somewhere here nutrition. Okay, some will be directed like this, and some will be you will be finding in the main folder. Okay, so you will find some of the sources, and you don't need to read each and every line from each and every article. You will just try to focus out some of all what are the important things which you should be knowing, and what are the must do things. Okay, and what is the UL perspective of this topic, why nutrition is important, how do you assess the nutritional status, what are the different component of the nutrition you are providing. Okay, and certain details you will be needing. Okay, so in these 5-6 sources you will find almost everything about nutrition, and you don't need to have repetition. Okay, so this is one thing. And I just want to tell you about the channel as well. If you will just enter any in the video from any of the video, you can go there, and then you can go to the playlist. Okay, and then you can find all the discussions which are being done in English. I am quoting them here as well. Okay, but usually the discussion we had done before, I have put them in the respective folder. Okay, so you can just have a look. Anyone who wants to approach, this will be the way, because majority of people have not subscribed the channel, and so that's why you will not be able to get it unless you subscribe it. Then it will be easier for you to approach, number one, and I will be spared from sending all the recordings again and again. Automatically you can go to the channel and you will find in the contents. Okay, so I hope you will be helping me out by doing this. You can see all the recordings are available here. Okay, so I just took few minutes before we start formally our today's topic. Okay, so there will be some people who have only background from anesthesia, but back in Pakistan, because we are dealing both in anesthesia and ICU, so some of the topics, the pure the people who are not working in ICU will be thinking that this is something topic not relevant to them, but actually the baseline information of majority of topics is the same, because anesthesia and majority time that ICU care with some of the patients who are needing it. Okay, or any patient who unanticipatedly decompensate will be ending in ICU. So ICU and anesthesia are actually part and parcel, and nutrition is very important when we are dealing with any patient. Okay, so now we will start. So Tayyaba, I will start from you. Why nutrition is important?
Sir, basically malnutrition, but the thing which we are concerning much is the malnutrition, that when you are not giving the nutrition as per.
No. Sorry, that is making you are oversimplifying the question. Okay, because if you know why nutrition is important, then you can go for the malnutrition. First of all, tell why nutrition is important. Why?
Okay, because it is, yes, it is important for our immunity. This is important for our, you can say, our wound healing. This is important for the even from weaning from the ventilator. This is important for the uh,
Like you, what you are telling and what I'm asking is the same thing. Only I'm holding the ear from the other side, and you are holding the ear from the other side. Okay. So nutrition. Why nutrition is important? Providing nutrition because usually anesthetists are very cruel. They don't let the patient eat. Either the patient is in anesthesia or the patient is in ICU. We are not taking care of the nutrition. Okay. So nutrition will have detrimental effect if you are managing a critically ill comorbid patient. Okay, because the body is going in which state?
catabolic state.
Catabolic state. Okay, where actually energy expenditure is increased than the normal. So in that case, nutrition becomes very important. So this is one thing, like you told, wound healing, like you told, weaning from the ventilator. You told the basic, like you see, nutrition will be needed for the ATP production. Okay, and if you are not providing the essential nutrients, the body will to find out some alternative way, and in that way the body will be going in the catabolic phase. Okay, and not only the requirement is increased in ICU or the part of what sort of nutrition we are providing intraoperatively, Tayyaba?
So it can be in the form of, as the propofol can give energy
No, no,
as
no,
1
no.
kilocalories per.
Propofol.
Yes, this
Mm,
gives us energy.
no, tell something better.
Dextrose.
Tell something better.
Dextrose.
Only we can
Uh,
give dextrose, sir. That is
Dextrose
only.
or ringer lactate which we are giving, or actually fluid is also a nutrient. Any fluid which we are giving is also a nutrient because it has electrolytes. Am I right? So electrolytes are actually whenever we are talking about nutrition, what are we talking about usually? Fat, carbohydrates, proteins, minerals, and electrolytes. Am I right?
Yes, sir.
Okay. So like you started with propofol. So Tayyaba, I'm sorry. Please don't. If they will definitely, they will not be asking you the question in that way, but don't try to start with something uh, which is not the first thing. Okay. So propofol is never a first thing to tell about nutrition. So just correct this. Don't try to start from something rare. Okay, or not rare. You can say something less important than any more important things. Okay. Okay. So
Yes.
okay. So Atik bhai, would you like to tell how to assess the nutritional status in any patient?
Sir, we can assess the nutritional status through anthropometry, and we can assess the nutrition status through weight and sir, through BMI, and sir, we can assess the patient by muscle wasting, by looking physically, clinically, like muscle wasting, like loss of subcutaneous fat, like loss of weight, and the second is we can assess the patient through anthropometric measurement, skin fold thickness, sir, mid arm circumference, hand grip, and BMI, sir.
Okay. Okay. So would you like to add? Anyone wants to add to this thing in a better way, a little bit improved way?
Yes, sir, and he has told very perfectly. But one thing which I want to add is you can say this is basically ABC. You can use the anthropometric measurements as he told BMI and the clinical assessment. Then comes the clinical assessment in which we use the term which is the subjective global assessment basically. There
Hmm.
are two parts of subjective global assessment. One is the history taking and other is the examination. In history we ask about the weight change of the patient, change in the food intake, functional impairment and the GI symptoms which the patient is having, either nausea, vomiting, or the diarrhea, and which we are seeing on examination. This include loss of subcutaneous fat, ascites, edema, muscle wasting. These things you use in the subjective global assessment for the assessment of nutrition.
Yes, in addition to that thing that I told you that in true basis, nutritional status is also related to the electrolyte imbalance. Okay, so indirectly, if there is some nutrition electrolyte imbalance or any problem related to decreased minerals or overall body, so it's part of. You can say that it is also part of assessment. Okay, so this is also part of, because the purpose of nutrition is also to provide these things. Okay.
So one thing, so one
Yes.
thing I want to add it
Hmm.
was, sir, we can also measure it in with the lab markers, that is albumin levels, transferrin, and sir, lymphocyte counts, sir, as well.
Ferritin, I guess, for iron deficiency.
And yes, sir, ferritin as well, sir.
Yes. Okay. So like, that's why I'm just telling you it's a very big top. It's a very like open-ended thing. So, but in true sense, you can say that it will be it can be measured from the usually from these subjective assessment tools. Okay, but usually if you go to the individual nutrient, you will have a lot of bigger picture. Okay. So because even the neurological problems which are occurring because of any nutrition deficiency, this will also be a part of assessment in nutrition. Am I right? The effects of the decrease in nutrients.
Yes, sir, you are right, sir.
Okay. So it's a conceptual thing which I'm telling you. This is not usually in the domain of the topic which they will be asking. Okay. But this should be in your mind that why nutrition is important. It is having all the hormones on all the system. Our body is running through the nutrients. Am I right? It is just like our fuel. So whenever there will be problems, some compensations will be done and some compensation will not be able to be done in specific patients who are at risk of something. As I'm telling you that there can be, whenever the patients we are dealing in ICU, they are usually having comorbidities or they are decompensated, they are in stress, so their metabolic requirement actually are increased. Okay, so this is how it should be. This topic should be approached in your mind. Like Tayyaba, you told that there is problem in the immunity. So what's the reason for it? Because all the inflammatory markers, when there is deficiency in the nutrients in the body, whole of the system will be disturbed. Okay, some hormones which are not needed will be increased and some hormones which are required will be decreased. Okay, so it's like whole of the balance will be go toward negative side. Okay, so next question is what are the different ways to provide nutrition?
Sir, there are many routes through which we can give nutrition.
Okay.
So first of all is the sir, the enteral route, sir.
Okay.
And second one is the parental route.
Okay.
And sir, the enteral route we can give it through normal orally we can give, and through NG.
Okay.
And we can give through feeding jejunostomy,
Okay.
feeding gastrostomy,
Mhm.
and percutaneous gastro or percutaneous
Like
gastrogenous.
gastrostomy from any route, okay?
Okay, sir.
Anyway, like you are directly giving in the enteral, and what are the advantages of providing the nutrition through enteral route?
Sir, it can give, it is more physiological.
Mhm.
It is the route of digestion and absorption,
Mhm.
and to maintains the physiological integrity and gut flora and function. It
Mhm.
maintains the barrier function of the bowel as well, and it release the rest, decrease risk of stress ulcer as well. So on these routes
Uh,
to
Yes, and in certain patients, if there are chances of patient going in sepsis because of bacterial translocation.
classification
Okay, so
decrease.
in that case, even it is better to provide nutrition through enteral route. So like it's more natural.
Sir, and sir, the it is that it is cheaper and it is easier to administer, and it is decrease of risk of infection is very less,
Mhm.
more gut protective, and it but it requires functional GIT. It is a disadvantage.
Functional GIT. That was my question. That in which condition you are unable to give, in which patient you will not give enteral nutrition.
So like
Like one of
intestinal,
them, like one will be any problem related to intestine, and another thing.
yes, sir. Another thing, when there is
It's
corrosive ulcer,
actually it's a part of the same thing, but actually you will mention it separately. If there is risk of aspiration is very high.
risk
Okay.
of inspiration.
Patient is in ileus, and patient, because if you are giving enteral nutrition, and patient is not able to have like absorption or through it, or patient is having high residual volumes, you will try to shift it to parenteral route. Okay, so we will come back to this point as well, but usually it is better to give in infusion form rather than giving in bolus. Okay, this is the most important thing which you should be considering even when giving enteral route, because mainly people are giving in bolus and then making it head up, but actually this is not the correct way. Okay, even in these this is part of a bundle as well. Okay, so it is better to give in infusion form rather than bolus. Okay, so this is an important point. So like I'm just trying to make it in a way that you are able to understand it rather than just covering some points from any specific book. Okay, so how will you calculate the nutritional requirement? What are different ways to calculate the nutritional requirement? Who would like to tell?
Sir, Assalamualaikum, sir.
Walaikum assalam. Yes. What are different ways to calculate the nutritional requirement?
So nutritional requirements are calculated by different ways, from ideal body weight, Harris-Benedict equation, and through indirect calorimetry.
What is the most simplest way from where we start?
So ideal body weight.
No. The simplest way that usually we say 20 to 30 kilocalorie. Okay.
Yes, sir. That is
20 to 30 kilocalories per kg per day. Per day. Okay. So this is the basic concept you should be knowing, that the other ways are sometimes difficult to apply. Indirect calorimetry will not be available. Okay, so first of all you will be calculating in a simpler formula, and then you can readjust, because it's not just like opening a box and putting it and close it. Okay, it's a constant process. So yes, in the exam they will be asking you about this Harris-Benedict formula, but for practical purposes you should be knowing that you can adjust it anytime, and more practical is to just remember this thing: 20 to 30 kilocalorie per kg per day. Okay, so this is one important concept. What is the other important concept? that whenever you are calculating the requirement, what other factors you will be thinking?
So you have
about
to add for fever. Sorry.
Just Rabia, continue. Tayyiba, I will add on some other things from you. Just Rabia, please continue.
sir, we will add the stress factors according to different situations. Like in surgery, we will add increase this resting energy.
No, this is one is a stress. One is a stress. I'm just trying to simplify it. One is a stress.
Stress, another is
Other-
sepsis, then fever, then surgery. So and burn. So
Yes.
because these are the states with the metabolism or
Activity.
hypermetabolic state, so we need to increase the percentage.
Yes, usually the most common thing, all are stress, but usually the common thing will be any patient in sepsis, any patient having fever, any patient having any hypermetabolic state. Okay, so in these conditions you will be altering it, and usual clinical conditions in which you will change the composition. What will be those common conditions? Tayyaba, this is for you. Which common condition in which you will alter the composition? We will go in detail step by step. You understand my question? And in which conditions you will try not to use the normal way, or you will give something extra, or you will add or delete it. Yes, Tayyab.
Diabetes mellitus, sir.
Okay, what will you do?
Sir, we will, it's a compromised condition. We will not add on the carbohydrate. We will titrate it according to the blood sugar level of the body.
Okay, what else? What else? What other condition?
Sir, when the patient is in chronic renal failure,
Okay,
we can change the protein.
you will reduce the protein intake. And
Yes.
anything else?
Yes, sir. Basically, we make a diet plan for these patients like renal failure and the liver failure. This is about the caloric density of the feed which we are using. That if we do not want to give a patient more fluid, so we increase the caloric density of that
Yes,
formula which we are
you
using.
are right. I'm just trying to go step by step, Tayyaba. So one thing Dr. Atik has told, that in diabetics you will have to titrate the carbohydrates. In renal failure you have to titrate the protein. Okay. And what common another thing which you, one important thing you have to remember.
In the liver disease, like we use the amino acids for decreasing the incidence of NCAF.
Okay. What else? There is one common you are
For
missing. Very common
for
thing.
diarrhea.
Or pulmonary, sir,
Pulmonary COPD. You are trying because the function of the lungs is not doing very fine. Okay, so you are just trying to reduce the carbohydrate so that relatively less CO2 is produced, because that will be having more load on CO2. Am I right? And how do you calculate this thing?
Yes, sir.
How do you calculate this thing, that which diet will have more load on specific thing? How do you calculate this thing? What is that concept? How do you say that this will have more load of CO2 and which will have less load of CO2? Respiratory quotient. Am I right? What is respiratory quotient?
Sir, this is oxygen consumption divided by carbon dioxide production, and it is measured through the indirect calorimetry.
But what is different for different diets?
Sir, it's like it is increased in respiratory diseases.
No. I'm just saying that if you are giving, because I'm just correlating this concept. Okay, I'm just correlating this concept that I just told you that in liver disease, or sorry, in the COPD, you are giving less CO2 producing things. Okay, so the most respiratory quotient is with glucose 1. Okay, and then protein it is 0.9. It is the same thing which you told, that it is the ratio between oxygen utilization and CO2 production. Am I right? So
Yes, sir.
fatty acids is 0.7. Respiratory quotient is 0.7. Okay.
Yes, sir. It's basically from the carbs. No?
Yes. So just you calculate it in that way. Which is
Yes.
on the top in the formula? CO2 or O2?
Sir,
Sir,
O2.
it is the CH, it is the carb, sir.
CO2 is on top. Okay, CO2 by O2. Okay, so that's why ratio is getting less for fatty acids or protein. Okay, because less CO2 is produced if you are giving proteins or fats than CO2. Okay, so this is just actually it's one of the yuck topic, pathetic topic to read, and even worse topic to teach, in my opinion. And I'm facing a lot of difficulty because I don't have too much extraordinary concept. So I'm just trying to simplify it as much as possible. Okay. So this is from where you have to start. And then Rabia, this which we said 20 to 30 kilocalorie per kg per day. What is it? What do you say this thing?
This is resting energy expenditure.
This is basal energy expenditure.
Sir, it is resting.
And what about this? Is it?
It is resting in energy expenditure.
Sir, basal energy is basically heat production due to metabolic from the BMR in rested and fasted state. And
Okay.
rested energy expenditure is the same energy from production or consumption through BMR in rested, not fasted state.
So which is fasting, resting or basal?
Sir, fasting is basal, no?
So that's what I was telling. That's what
But
I was
sir,
telling.
okay.
The fasting is the first thing which we calculate is basal energy expenditure. Okay.
Yes, sir.
And then when you are eating it.
In basal, when we multiply by 1.2, it becomes the resting expenditure become sir, basal expenditure, sir.
Okay, so one is fasting and one is after we take the food. Okay.
Yes.
So
So
can
this
you repeat it, please? The difference
Because-
between BMR and RE?
Rabia, please speak out.
Sir, basal energy expenditure is basically heat production of basal metabolism in a resting and fasted state, which is you said rightly that which is 25 kilocalories per kg per day. And the resting energy expenditure is energy expenditure of basal metabolism in rested state, but not fasted state. So the resting energy expenditure is 1.2 times of basal energy expenditure.
So that's what actually I was saying, that first is basal, and then
Yes,
when
sir.
you eat it, then it becomes resting energy expenditure. Okay.
Yes, sir.
One is basal. Basal means basal, and then resting without any activity, without any stress, but after eating. Okay. And then you
Sir,
add it.
can I define, sir, daily energy expenditure is expressed as basal energy expenditure. Basal energy expenditure is defined as heat production by basal metabolism in the resting and fasting states, sir.
Okay.
And simple equation for basal energy expenditure is kilocalorie per day is 25 into body weight in kilograms.
That's
And when basal energy expenditure is multiplied by 1.2 to allow thermal effect of the body, then just like fever, mild stress.
No. Please, Atik bhai, just correct this thing. Just let me repeat it again because people are confused now. The energy the energy requirement when patient is NPO is basal energy expenditure. Okay. This is by either we can calculate it with the indirect calorimetry or whatever simple way we are saying 20 to 30 kilocalorie per kg per day. Then when the patient is having food, now there is energy, increased energy is required to metabolize the food. So then you multiply it by 1.2 times. Okay, so then it becomes resting energy expenditure. Then next step is to add the stress. Okay,
Yes.
stress is mild stress, moderate stress, severe stress. Usually in the ICU, usually this stress is severe stress. Okay, so this is you multiply it by 160 for example 1.6. So for example, if we just calculate in a simple way, we just first multiply 70 by 30, so it becomes 2100. Then you multiply 2100 by 1.2, whatever number it comes. Then that number, for example, it is, for example, 3000. I'm just giving you an example. And then you multiply it with the severe stress. So it becomes, for example, 3360, for example. Okay, I'm just giving you an example. Then now next step will be that you have to divide it in the different things, different caloric things. So the basic concept for that is that usually you will not count proteins. Proteins you will count separately. You will not count in calories. Okay, and this is to prevent the nitrogen. It is to maintain the nitrogen balance. Okay, balance. So you will take fat and carbohydrate. Okay, so yes, how much fat you have to take and how much carbohydrate you have to take will be according to the patient condition. Okay, but usually it is 70% carbohydrates and 30% fat. Okay, 70% carbohydrate and 30% fat. Okay, this is you understand this concept: basal energy expenditure, fasting, then you take food, then it became resting energy expenditure, then you add it as stress, and now, for example, whatever number you have achieved, now you have to do, so you have to make it in the divide it in the basically carbohydrate and fat. You will keep proteins separate. Okay, so on background of it, there is another thing which is very important, is the fluid calculation. So fluid calculation, you will be doing it with the same for Holidar and Cigar formula, this 4-to-1 formula. Okay, and you will add the requirement of fluid according to all the factors which we usually calculate in the perioperative period, in the form of insensible loss, in the form of third spacing, in the form of drains, okay, in the form of blood loss, whatever, any drain, so you will add it. So this is one concept, that you will calculate the fluid requirement or fluid amount which you can give to the patient. Okay, in some of the patients you are giving combined, you are giving some enteral feeding and you are also giving some combining this fluid. Okay, so in either case you have to keep the fluid balance intact, and usually you should not keep it negative, but you should not make it too positive. Okay, everyone understanding what I am trying to say? That you have to, yes, this will be the background over which whole of your party will move on. So fluid should be calculated, and this is the practical aspect, that if a patient is on restricted fluid because of any cardiovascular, respiratory, pulmonary, renal, whatever cause, you have to keep in the considerations that even they have to, the nursing staff in the ICU, they even have to calculate all the infusions they are giving. Okay, and it's the same thing which you were telling Tayyaba, that we will make the fluid restricted by making it more concentrated. Okay, as much as the the osmolarity of the solution is tolerable or compatible with the body. Okay, so this you can make it more concentrated, or as much as the possible for the body to tolerate it. So this will be your mechanism, and you will be calculating paracetamol, even 100 ml you are giving, or you are giving any antibiotics in fluid, you are giving inotropes in fluid, you are giving vasopressor in fluid. So you have to calculate every fluid in it, and whenever the patient is in fluid restriction, you have to guide the nurses that they have to restrict the fluid even in the any associated fluids which you are giving, and by making it concentrated, like you can make the concentration of the vasopressor concentrated, and the syringe pump will automatically adjust the volume it is being injected. Okay, so this is the main concept we should be knowing, and then you will now put it in this carbohydrate and fat. So how much is the calories which we achieve from carbohydrate and proteins and fats?
So 1 gram of carbohydrate give 4 kilocalories per grams,
Okay.
and we need 4
No,
grams.
proteins.
Yes.
Proteins, how much?
And for proteins, it is again 3.75 they say, but for remembrance, I have taken it as 4 kilocalories per day, and from the fat, 1 gram gives 9 kilocalories per gram.
Yes. Actually, if whatever I remember or whatever source I had read, it was low for glucose, then protein, and then most for lipids. It is 3.7,
Yes, right.
3.74 and 9.1, which is written in the source from where I am recalling it. Okay. 3.7 kilocalorie per gram, 4 kilocalorie per gram, and 9.1 kilocalorie per gram. Okay.
So I forgot. So I just take it as 494. So that's why.
Yes. You can do it in that way, but least is glucose and most is lipid. Okay.
Yes.
That's why in our Pakistani culture or even Arab culture, fat is very important. Okay, here the caloric intake, even in any people, they are not taking the food quality which actually we take. It's our food quality is pathetic, and the food quality which are the other parts of the world, they are taking very high quality food as compared to what Pakistani Indian people are taking. It's I can appreciate. I cannot eat the Arabic food because of the less spices, but the quality of the food which they are taking is much better than our quality. Okay, this is an auxiliary comment. Okay, so so this is one thing, and then how much preparation of carbohydrate you will be giving usually? %25 or 50%?
50%.
Okay. Actually, it's not fixed rule. Remember one thing, I will tell you after a few minutes that usually what is the mechanism. Okay. And then what are the usual preparation for this one fat?
It's given in the form of like I forgot. It is
10% or 20% or 30%?
yes,
Okay.
intralipid 10%.
It's not intralipid. Please don't mix you up.
Okay,
Intralipid
sir.
is for local anesthesia toxicity. Don't use that one. Okay.
Okay,
Lipid
sir.
preparations. Okay, lipid preparation. And what's the difference in the lipids which they are using? Intralipid. It's a combination of the chains which it is there. Okay.
Okay, sir.
So this is a thing. So you will be calculating the calories, you will be calculating the fluid, and then you will calculate the how much volume you have to give, and you combine it. Okay. And the last
Sir, we in Pakistan we commonly give the interlipid an emulsion, which is produced from soya with the chylomicron size particles. Actually, you are also right. Lipid preparation are actually very expensive, but it can be given through parental nutrition with low levels of lipids.
no, I'm telling something else. I'm just using it. She has used the word intralipid. Intralipid is being used for local anesthesia toxicity preparation. Don't mix it up. It is lipofundin or lipo. If I remember the word, the preparation which when I used to do ICU was lipofundin, if I'm not wrong. I don't know exact composition of it. And usually it is either 10% or 20%. Okay. So now the comes to proteins. So protein requirement is usually ranging from how much to how much?
35 to 40 grams per liter.
No, what is this?
1 to 1.5 gram per kg per day.
Yes.
in a normal person.
0.5, 0.5, 1.5 gram per kg per day. Okay.
Sir, I was taking, I misunderstood. I said, I understood that you were asking about the composition of a
No.
formula.
No. Protein requirement. How much is the protein requirement to maintain the nitrogen balance? Okay. And how we calculate the nitrogen balance? By intake minus urinary nitrogen. Okay. Am I right?
Yes, sir. Basically, there is a formula of protein intake divided by 6.25 minus urinary nitrogen. Yes.
Yes. And what about this 6.25? What is it?
Sir, this basically means that I think 1 gram of nitrogen is giving 6.2, 1 gram of protein is giving the 6.25 something nitrogen.
Nitrogen, okay.
Something like that.
And in urinary nitrogen, we add also 4. That is for fecal. Okay. Because fecal nitrogen is we cannot calculate easily. So we calculate the urinary nitrogen and plus something for the loss in the feces. Okay. So that's how we calculate the nitrogen balance. To make it simplify, the purpose of giving proteins is not to provide the calories. Actually they are giving calories, but we keep it for maintaining the nitrogen balance. Okay. So we have to keep positive nitrogen balance around 4 to 6 gram. Okay. And
sir, in my understanding, negative nitrogen means that your body is using the muscles as energy, and your body is a source of energy. Okay.
Catabolic.
Yes. Okay.
So that's why if a patient is critically stressed patient, so you have to increase the nitrogen intake, increase the protein intake, as occurs in sepsis and burns. Okay. So this is the reason behind it, is that one. Okay. So so this is how you will be calculating it. People are really crazy. I never understand this Harris-Benedict equation. I tried it. If you forget, it is actually because of the parameters you should not forget, that they calculate it with the weight, height, and age. Okay. And there are different numbers for men and women. Okay. And make it simplify, you take it as 20 to 30 kilocalorie per kg per day. And then you divide it into carbohydrate and fat in 2 steps. First of all, you will be calculating the fluid requirement, and then you will take the preparation. And actually when what happens that in ICU, every patient is being seen by the nutritionist. They take in consideration all the clinical scenario. Okay. Then they calculate the fluid requirement. Then they calculate how much carbohydrates are needed, how much proteins are needed, how much calories are needed, which vitamins, electrolytes they are being needed. Okay. According to the lab works, albumin, like we did, transferrin, and everything, every electrolytes and every parameters which you are using it in different conditions, and then they make it a combination, make it compatible, and then it is given IV through in a same syringe pump. Even it is available even in Pakistan, it is available in some centers where they calculate it and give it. And almost there will be some difference between enteral nutrition and parenteral nutrition. We will just discuss later on. But the concept is that usually they can be given separately or they can be given together. Okay. If we are in a separate special setup where this facility is available, that is better, because it will be having a specific hypersmolarity, and it will be calculated and it will be given in one go, rather than given and there will be trust and crust coming. Okay. So this is important. I'm just trying to tell you the important points which you should not forget. And among the vitamins, what are the main groups of vitamins which you should be remembering? And one is fat soluble vitamins and one are water soluble vitamins. Okay. So which vitamins need to be replaced earlier than others? Which vitamins have more store in our body relatively? Fat soluble or water soluble?
Fat soluble.
I'm sorry?
Fat soluble.
Fat
Sir,
soluble.
fat soluble?
Yes, fat soluble. Okay. They will, and actually both of them are important. So what we like, we have to calculate the daily requirements, and then we have to give it accordingly. So another important point at this point of time is that how will you choose between different preparations? Sorry, how will you choose that this patient needs enteral nutrition, and this patient should not be given enteral nutrition, or what factors will be deciding it?
Sir, ideal is to give the enteral nutrition if the conditions allow. Like if patient gut is working functional, then we should use enteral feeding. And as you earlier told that when there is the non-functional gut, IBS, short gut syndrome, any fistula, any gut malignancy, obstruction, then we would not be using the enteral feeding. And then we will go to these are basically indications. The contraindications of enteral are indications of parenteral nutrition. So the conditions when we should not be using the parenteral are severe sepsis, patient in shock, patient who is going according to assessment is going to eat or going to have enteral feed in next few days, and the patient in having no prognosis and
Okay.
patient in DIC,
Okay.
leukemia.
So when you start nutrition, what in enteral nutrition you have to take consideration of the residual gastric volume. Okay. And if you are giving parenteral nutrition, okay, what you should be taking. This is also for enteral nutrition, but here another thing what you will be thinking is development of refeeding syndrome. Okay.
Yes.
If you start nutrition very fast, what happens? What is refeeding syndrome?
Sir, basically,
Just a second. Rabia, let someone. I will try to ask to someone else. Atik bhai, what is refeeding syndrome?
Sir, it is the potential fatal condition in which the patient develops the carbohydrate load to deliver after prolonged fasting, 4 to 5 days.
No, actually, what is the reason? You see, forget in this answer, delete this very exciting word of life-threatening in the start. Okay, what happens actually when we in a fasting patient or in any patient, when we start a heavy load of carbohydrate, what happens? If you have a meal and after that, what happens to you? Even refeeding syndrome occurs to us as well.
When the patient is on prolonged fasting, and then there is decreased level of insulin, and the fats and protein stores are mobilized to give energy. Then the fats breakdown of fats and muscle with the loss of potassium, magnesium, and phosphates. On starting carbon dioxide, sudden circulation of the insulin occur provokes intercellular potassium, magnesium, phosphate, and calcium, which drops the level of sugar, sir.
No, Atik bhai, please, no, not like this. The last word is deleted. Patient was You are
Causing-
just try to minimize the words. Try to minimize. You are going in too much detail. Very
Achha, okay.
simple. What happens? Very simple. Just try.
Yes,
Go try
electrolyte-
again.
Sir, electrolyte levels will be disturbed.
Okay, which will
causing,
have effect on.
hypophosphatemia, sir.
What will be the
Hypomagnesemia.
result? There will be decrease in electrolytes because insulin will throw
So
them
sorry.
into the cells. So suddenly the blood levels will decrease. So what will happen actually?
Actually, sir,
Okay,
arrhythmias will happen. Arrhythmias will happen. CVS will be unstable. CNS will be unstable. Respiratory arrest will be occur, causing severe arrhythmias, seizures, cardiac arrest, respiratory
Okay.
arrest, and death
That's
can
it.
occur.
That's it. That's it. So rather than having so much detail, you just go relax and just start with this thing that when patient is fasting, suddenly when you give a high caloric food, suddenly there is surge in insulin, which will move the, in addition to this carbohydrate, it will suddenly increase the intake in the cells. So there will be decreased concentration in the blood, and it will result in serious problems in the respiratory system, cardiac system. Patient can have arrhythmia, seizure, and respiratory failure. Okay, so this is, so how to prevent it? How to prevent it, Adik bhai?
In prevention,
Hmm.
we have to optimize the electrolytes before
No, no,
and sir,
no.
start feeding at the
Slowly.
decreased level.
Yes, yeah, this is more important thing. Okay, electrolytes, how you don't know how much they are decreasing. So the thing is that you will be starting slowly, gradually build up. This is the answer for refeeding syndrome.
And sir, monitoring the electrolytes like
Monitoring the
say,
electrolyte, monitoring the electrolyte levels, and just this is what you should be knowing. Okay, so my next question, up till now, are you understanding? I'm just trying to make it as palatable as possible. Tayyaba, what are the considerations of the lines or considerations related to the osmotic effects or the immediate effects of parenteral nutrition?
Yes, sir. There is basically these enteral nutritions or the maybe hyperosmolar. So some nutrition can be given from the peripheral axis, and for some nutrition, for some total parenteral nutrition, we might be needing the central axis. So the osmolarity, low osmolarity fluids which can be given from the peripheral axis should be less than 850 milli osmol per liter. And greater than this, you will be needing a central axis.
No, I'm sorry. Maybe I have not explained my question. I'm talking about the concerns in the parenteral nutrition, because
Yes.
of the lines related problem and the preparation which you are giving, rather than the real I'm not asking about this this refeed, other than refeeding syndrome.
Okay. There may be catheter related risks.
Yes.
I'm if I'm not taking it wrong, you might be asking about the catheter related risks that can be pneumothorax, hemothorax.
Yes, catheter related.
There can be infections.
Yes. So how, if
central
you
venous
specifically,
thrombosis.
yes, thrombosis, because they are at risk, they are bedridden patient, they are at high risk of embolic phenomena. Okay.
Yes.
So what is a way to avoid this specific problem? How can you avoid this thing?
So ideally, if we should not be starting a patient on directly on the parenteral nutrition,
No,
we
if
must be.
no. Of course,
Okay.
this is
If
always ideal. Okay. So if you want to give an vein, so is there any way you can?
Okay, then yes, you can give from the peripheral axis. Yes, there
Yes,
are feeds that can be given from the peripheral axis.
Yes, so it is called as
that is known as parenteral
peripheral nutrition. Okay.
Parenteral nutritions. Yes.
peripheral parenteral nutrition through the this PIC line.
Peripheral access. Yes.
Okay, so you can give it through the peripheral line. You can give it through
Sir,
PIC line. You can give it through
But
PIC
sir,
line. Yes.
But she was a right to, of giving less than 850 milli or smaller. It can be given through peripheral lines, sir. And through CVP line, we can give more hypertonic solution, sir.
Yes.
She
Yes.
was
This is right. You are. This is about the composition. So this is the other aspect, and the lines related thing you can avoid it by using the peripheral line. So this is what. So like some words about because the rest of the things are the same. Okay, rest of the things we have already discussed actually. So some words about actually I just want to show you something which a majority of the people not aware of here. Because I'm sure nobody has seen this. Actually, this is they are called as packed modules. Okay, patient-centered, something like that. This is for actually for European diploma in intensive care. Okay, but some of the things are written in a very nice way. Like I will just show you this thing that this is for enteral nutrition. Okay, so this is the same thing which you know. I just wanted to show you. You can have some ICU topics from here. They are written in very nice way. Okay, so okay, so there is functional GIT or functional GIT not present. Okay, so if there is no functional GIT, then you will be going towards the parenteral nutrition, and we assess whenever you want to. We can start. You will start. Okay, then you go towards the other side. You will see the start continuous enteral nutrition at 500 ml per 24 hours. Okay, and then you will be monitoring the this one
Residual volume, sir.
residual volumes. Okay, and then you will be if it is less than 500, you can increase the flow rate. Okay, and if it is less, then you can add some erythromycin or prokinetic agents like domperidone. Okay, or things like that. If it is more than 500 ml, then you will just try to manipulate. I don't know what they have written here.
Yes, sir. With the thing which I understood from this, basically, when in the older studies, when the residual volume was greater than 500 ml, some authors suggest to just
Stop
stop
it.
the
But
enteral
here you will
nutrition. Yes,
be
but
you will
they
be continuing it.
yes continue it with the 500 50% less infusion rate. So
Yes.
do not stop the enteral nutrition is the key concept of this.
Yes, this is what, and this is also medicine which this is just like domperidone. It is also prokinetic agent, cisapride. Okay. What is the only contraindication to nutritional support? Severe shock prior to hemodynamic and respiratory stabilization. Anyways, this is actually I will just show it. Just a second. You can find these modules in ICU, and then you will find it here, ICU pack modules. So actually this is recommended for European diploma in intensive care. Some of the topics are in too much detail, but actually the way it is written is really nice. You can read it when you have background knowledge, then it becomes even easier for you to read these things. Okay. So some of more details are required for actually enteral nutrition. So what are the components which we are giving in enteral nutrition? And there are some branch chain fatty acids, or sorry, amino acids, and there is some concept of absorption. Sorry, there is some concept of adding some fibers. Do you know about it?
Yes, sir.
What are those, please, Rabia?
Sir, the components, first of all, when we use the formula with the osmolarity of 300 osmol per liter, and it contains 1 kilocalorie per ml. So it contains carbohydrate, proteins, fats. 1 second. The main components are these. We add the fibers into it and additives as well. So carbohydrates in the form of polysaccharides and fats in the form of polyunsaturated fats like vegetable oils and fish oils, and proteins in the form of amino acids. And fibers are fermentable and non-fermentable fibers. Other additives are electrolytes, vitamins, trace elements added to in the formula.
Yes. My question, which actually
Sir, we can divide it into macronutrients and micronutrients, sir.
okay, what how will you
The macronutrients are protein, fats, and carbohydrates, and macronutrients are vitamins, minerals, and trace elements like zinc, copper, etc.
okay, actually I am confused myself, and that's why I'm a little bit distracted at the moment. Can someone explain, because I didn't know, I was trying to think whether I couldn't recall why we are giving isoosmotic solutions in the gut and we are giving hyperosmolar in the IV. Do anyone knows about it? You understand my question now?
Sir, just to, I think it's for keeping the fluid balance, not drawing more water into the gut from the.
No. That is for, so actually this is right. But why we are giving so much more hyperosmolar solutions in the IV?
Sir, to reduce the volume. The volume
So
actually.
shouldn't it be because this has totally, I had a wrong concept before. I that's why I'm a little bit shocked at the moment, because sometimes you got stuck in something, and especially if you have a wrong concept in your mind, you feel more embarrassed. That's what I'm embarrassing. So if this is not a fair enough indication, if anyone, so a fair enough explanation. So can anyone? I will repeat my question. That we stated that we can give a relatively, or you see, it is, if it is 300, it may be 400, 500, fine. Why we are giving up to 1000? This is my question.
1000.
Yes, Tayyiba, do you have some explanation for it?
No, sir. Sorry.
Okay, so I think I'm keeping this question open to anyone. Anyone knows about it?
As I understand, is that in renal patient, when renal disease patient, when we give a formula of having like hyperosmolar and with low volume, that hyperosmolar is given to reduce the volume. So
No,
isn't
that makes sense. But why this is too much? Difference between 300 and 1000 is too much. I'm sorry, I
Yes.
don't have this answer. I will try to find out the answer, and we can I can share it to you. Okay.
Okay.
So in the nutrients, there are some immunonutrients like glutamine. Okay. So these questions they can ask you in MCQs. Okay. And how to monitor the nutrition by, if there is line, so you have to keep the line related things, X-ray and ultrasound, okay, to see the tubes or lines, okay. And you can have residual gastric volume by, what is the latest modality to check? Ultrasound, okay. Ultrasound. And then you should be taking care of the infections, okay. So like you can have if you are giving constant through lines, which line is the most suitable? If you are giving through central line, among the central line, which line is
Internal jugular, right internal jugular.
no, related to infection?
Subclavian.
Subclavian.
Subclavian. Okay. And so this is of course the ease is more in internal jugular, but for this one infection control for long term, and you can tunnel it. Okay, so tunneling will reduce the rate of the development of infection. Okay, and then you have to maintain the blood sugar levels. You have to maintain the for example, there is hyperlipidemia. What can occur?
Hyperlipidemia, sir. It can lead to anti-inflammatory inflammation in the body, acalculous cholecystitis,
Liver dysfunction, acidosis.
hepatitis.
What
Yes, sir.
happens in propofol infusion syndrome? Some pictures should be like that. Okay.
Yes, sir.
So you should be, and there can be some development of pancreatitis. Okay, it is one of the factor for development of pancreatitis as well. Okay, so you should be keeping more important. You have to take care of everything, but usually you have to take care of the acid-base balance, potassium, calcium, magnesium, phosphate. Okay, and the vitamins. That's what you can monitor. Okay, and then you have to, when you are starting it, you have to start it slowly, and then you have to gradually build up to prevent the refeeding syndrome. Okay, and okay, so liver failure, you told that protein should be given less or what?
Altered amino acid, they say, should be given, and low sodium should be given in the liver disease patient in the diet.
Well, similar is true for renal dysfunction.
And for renal dysfunction, low potassium and phosphate, and it's high osmolar, that is 2 kilocalories per liter and per ml, sorry,
Per ml.
and having lower volume. Yes.
Okay, so my another question, how you calculate the requirement by obesity?
So in obesity, it's according to BMI. So basically,
No, calculation. How you will calculate it, ideal body weight or lean body weight or what?
so ideal body weight.
Ideal body weight or lean body weight?
So actual, sorry, it's actual body weight. But I have read is actual body weight.
No, sir. I think it's ideal body weight plus 20% in obesity. That
So
is the
this is-
lean body weight.
So this
In
is lean
actual,
body
this is
weight.
the lean body weight. Yes.
So this is lean body weight. Okay.
So I have read actual. I will confirm it.
Just confirm it. Just confirm it, please. And I will request you, if you find something different, like we are discussing this thing, if you find, please comment on the YouTube. Okay. Like daily Dr. Akhtar Wahid, our sir, I'm really thankful to him. He daily comments something. And I will be very happy if all of you just have a comment, anything good or bad, or anything which we did mistake. You can see we are not I welcome if someone will be correcting me. I will be very happy rather than getting angry that why you are correcting me. Okay, this will be help to me rather than yes.
Sir, your previous videos have did not give us this opportunity because your comments are off.
I'm new to this game. Now I have known, because there was an option of making it for kids. So I was very apprehensive that I have to make it for kids. So that what happened that if you are making it for kids, the comments are off. But recently, forget about the past. Previously, we were discussing in our Urdu and Punjabi language. Now we are formal. Okay. So now you will find later on, if some of you pass and don't run away on your Ferrari on world tour and stay with me, I guarantee we can improve a lot. But I am a human. I cannot continue it for long alone. I cannot do it, believe me. Okay. So
So that's why Bistangul has decreased a lot, sir.
I'm sorry.
That's why Bistangul has decreased a lot, sir.
What's that? What is reduced now?
Bistangul, sir, Bistan.
Yes, yes. Bisti. Okay. That is your, that will be success, your success. Okay. So, okay. So I think I have tried to make this beautiful topic as less horrible as possible. If anything, anyone, we will have some fun before we finish. Okay. Just a second. I would be very happy if you people have a look on this art. Like, yes, Tayyeba, you want to say something?
Yes, sir. Before, after you finish this, then I will ask one.
You start this thing. You ask first, please.
Sir, I just want to ask someone if you can told me how to make a feed of, just for example, if they can say that your patient has an energy of
70
the,
kg.
you can say the requirement of your patient is 2500 kilocalories. Okay, right? So
Just a
just
second. You see, I
tell
will
us what.
show you because one of my friend is not here now. Can you believe this? That this notes looking very ugly, and I was actually taking help from this notes. Okay, because this was made by, you see, you can say the name Aves. He is my teacher. I am teacher in anything else than studies, and he is my teacher in my studies. Okay, so these notes were made in somewhere in 2011. Okay, but believe me that this is valid up till now. So that's what you were asking me, and that's why I use the word this 3360 like that. Okay, so this is basal and energy expenditure, then we multiply to make it resting energy expenditure. This is the Harris-Benedict equation. This is the stress level, then protein requirement, calories, and this and that. Okay, so this is how you can just convert it into just a second, please. Okay, so you can convert it into, I think that's what you were asking, or something else.
No, sir, I was asking about the how you can divide into the lipids, proteins, and carbohydrates. That 40% of the
That's
total
what is there.
can be
That's
given.
what is here. Just have a look clearly. This is the what you were asking. You are asking. Okay, that how many mLs, how much will be given this one, how much will be given this one. So you can then calculate with the percentage. You understand?
Okay, sir, I will have a look on this. Okay, okay.
You understand? This is, you see, he has given example of 70 kg. Okay, because adult is 70 kg. Okay, so this was the calories he calculated with the severe stress, and then he labeled it. If it is 10%, it is 100 gram per ml. So usually it will be like that. So usually it will be 70 kg. It will be 100 gram. So it will be 1 liter. So the 1 liter will be this one. Okay, and then fluid according to the Holliday-Sikar formula. Okay, or he has written here 30 ml per kg. It will also come like that. It's almost similar. And then you will calculate according to the preparation. You can do it easily. That 1000 calorie will be through fat, and this calorie will be through carbohydrate. Okay. Okay, so what are the answers to this question? Resting energy expenditure is defined as the energy expenditure of the body in the resting state. Which of the following statement is true? RE is always less than or equal to EE. This is actually basal energy expenditure, which we were telling. Is it less or equal or more?
It would be more.
Okay, so RE is not affected by the body temperature.
This is false. This is affected by the body temperature.
Yes. RE measured in terms of body mass is equal in females and males.
No, it's false.
Resting energy expenditure is often the range of 20 to 30 kilocalorie body weight in ICU patients. Let's see.
No, sir, D is false.
The
Just
D is true. The D is true.
This is true.
so let us see. So it is true, false, false, true.
True.
So actually, I think I was always less than or equal to energy expenditure. Actually, I pardon if I use the word resting for BE or BE for resting. But the concept is one is fasting and one is when you are not fasting. So maybe I am confused with the word because this
Sir,
word,
B when it is fasting.
yeah,
Rested
no,
and fasted. You can imagine it when a person is sleeping, that he is resting
is
and is
basic.
not eating. So, but in the resting energy, patient is, is resting, but he might be eating or having something, not fasted.
So this is the last one is correct, and this one I'm is still confused. Okay, so
Sir,
apology for that.
it is true or false?
This is true. They have written it's true. That's why I'm confused. Okay.
Less than or
Just
equal to.
reconfirm it. Actually, this is not a big thing. Please, I apologize to everyone if I'm telling the wrong thing. One is fasting and one is after eating. Whether it is resting or basal, please confirm it. Okay. So that's the concept I'm giving you. So what is the answer?
Basil is fasted now. Many I told basil is rested and fasted.
Anyways, just we have wasted a lot of time. Next question, please. Next question, please. Atik bhai, what you are saying?
Nitrogen balance.
Atik bhai, what you are saying?
Sir, basal energy expenditure are both resting and fasting state, both.
No. Okay. Just leave this point. What is the ideal marker for protein calorie malnutrition?
Nitrogen balance should be.
Nitrogen balance. Let's see. There will be some answer, some reason for it.
What about, sir?
They have made it all false. Ideal will be something else. Actually, this is you will have this pack modules with you. Okay. So if you want to have a look at it, because I'm actually tired now. I have to go somewhere out, and so if something is missing, we will inshallah discuss again. And thanks a lot, all of you, for your presence. Okay, so we will try to discuss poisoning tomorrow, inshallah. Okay.
It includes snake poison as well.
I will try. Actually, after
Okay.
a few days, I'm leaving for Pakistan, and I may not be able to continue in the way I'm doing it here. Okay. So because I will have
So
a lot
for
of,
how many days? For a month?
yes,
I
I will try to continue. Okay. But that's why I'm saying, please,
In
I need
Pakistan, you will be more free, na? There's
more
no
free.
work.
No. Here, here I am free, not free in Pakistan. I will have some family assignments there. I will have to
Sir, please
travel.
spare 1 hour daily, sir, please,
I will
if
try.
possible.
I will try, inshallah. Okay. But
Thank
you
you.
see, I request all of you, first of all, just try to help me out by discussing in the group. Okay. We have around 4,000 people on board. Believe me, you'll be surprised. If 4,000 people discuss one point each daily, you can imagine how much we can learn together. This is one thing. The other thing is that even I'm not taking before, because this Zoom meetings and everything is recent and last 6 months. And this shar, I will use say that this shar of Corona actually started this khair. Okay. Because before I never did this. In last 6 months, I started all this. Rabia is here with me, and Atik bhai is with me all the way together. Okay. So this is one thing. WhatsApp group is all the way together. A WhatsApp is always available. So whenever you want to ask anything, any of you, you just drop a message on WhatsApp, and it will be, I can answer that thing anywhere, wherever I am. Or I would ask all of you to participate. Okay. So this is because this is something new, but discussion on WhatsApp is always open. round the clock. Okay. So thanks a lot, everyone. And again, I will say, all of you subscribe the channel so that I am not free from this tension of sending the recordings daily. Okay. So you can then find all the recordings from the channel and spread the message that, do you see? Yes, last thing before we finish, you know, the experience of the people of exam today, one of the person which I was not expecting at all will fail today. Number one. Number two is Zishan. Zishan is actually unfortunately failed. And another thing is that today, even I discussed with some of the examiner, the exam of MCPS was even more difficult in some aspects than FCPS. So the people who are doing MCPS, I request finish off this query of difference between MCPS and FCPS. You are having more burden. You don't have entry exam. You don't have intermediate exam. People just make you usual. I'm not saying for all of them, but majority people, there is fault from both sides. Okay. The people, because are taking it for granted, it's imprinted in their mind that this is an inferior degree and I don't need to study and I will pass. Or this is one category, or the other category is that they don't care because they have just entered and they are taking it for granted. But believe me that I don't find any difference between MCPS and FCPS in the way that the topics are the same. Okay, anything can be asked and the basic safety will pass you or fail you in the exam. So please, and this is one thing. Another thing is that just try to understand this point, that when you know the knowledge, I did not try to make this topic in a very stereotypic way by opening just discussing 1, 2, 3 points from the book. I just try to make it the highlighted points. I try to highlight the main points. I try to highlight first. Okay, so that's what I will suggest you. Just make this order and then everything will become easy. Okay, thanks all of you, and inshallah we will do poisoning tomorrow. Bye bye.
Sir, no.